We're going over to the final live case for this session, which is Dr. Saito, who's going to do a 6 French virtual 4 complex angioplasty. Dr. Saito, Ferdinand, can you hear us?
We can hear you.
Okay. I'll hand you over to the panel for the live case, Ferdinand. Thanks.
Thank you very much. Well, let's introduce the patient. The patient first is a 78-year-old male with recent onset stable angina, but his last inginal attack was last night, quite severe. So he's happy to be here on the table. This patient has some risk factors, hypercholesterolemia, hypertension, and a positive family history. On physical examination, no abnormalities. His EKG shows cues in the infralateral leads. This patient in the past had sustained a subclinical infralateral infarction. I forgot to say that. On ultrasound, his inferior wall is hypokinetic, and we performed a coronary angiography not so long ago. It was January 30 with a 4 French catheter. In total, 41 cc's of contrast was used, and again, this patient, because he had to be here again today, had a light compression bandage, and he had today, fortunately, his radial artery is open. The patient had a wrist fracture in the past, so his arm is a bit painful. Well, the strategy is to show you a sheathless 6 French technique. It's a technique that I am not familiar with. Dr. Saito is experienced. He will show that to you. And afterwards place a BVS in a distal CX. You see the image on your screen. It's a subtotal lesion distally in the CX.
Ferdinand, we don't see the image.
Okay, I'm sorry for that. I have to ask technicians to show the slide of the second case. They are downloaded. Can you see it?
No.
Okay, then
we take a picture.
We will make pictures from here. Okay, Dr. Saito is doing the procedure. We have the assistant of Irene and Dr. Saito show what you do and what you have prepared already.
Okay, normally the radial artery puncture is made by using 22 or 23 gauge needle, is right? And that means the wire inside we can pass is only 0.025.
Yes.
It's too small to navigate this guiding catheter. So we have to exchange the guide wire to the big size. Big size means 0.35, okay? This one. This wire is TL wire made by Terumo and in conjunction with Asahi. So anyway, for this case, first I put the 4 French introducer here, okay? Because I have to exchange the wire, upgrade the wire to the 0.35. And the outer diameter of this sheath is smaller than this catheter, or equal to this catheter. So that means this system is called as virtual 4 French. You understand? And this is a sheathless guiding catheter. Actually, the outer diameter of this catheter is 6.5 French, made by Asahi. And outer surface is very hydraulic coated. And of course, we have to place the inner catheter, and this is the inner catheter. But before inserting this catheter, I always bring back this inner catheter, because otherwise, if we push this inner catheter, you can see that this part is straightened, and we'll lose the curve. Okay, now I'm ready. So I will put this TL wire.
Why it has this special curve?
Because this is also the tip is hydrophilic, so it's very dangerous to make a perforation in the branch. That is the reason. Okay. So in the 4 French introducer, I'm putting this wire, and I have no resistance, so the maybe okay. So I'm pushing. I have some resistance. So.
A nice loop.
Here the artery is so too much.
It's probably a high takeoff radio.
With the diagnostic angiogram, we had no problem. And
yes, already he had radial angiography.
Yes.
So
it was not. He did not encounter resistance there. So maybe you're in a side branch.
Yes.
In this case, we are doing normally an angio.
Yes.
To see if it's a high takeoff radial and if there is a connection at the elbow level.
Yes.
And after that,
okay.
we move,
it's better to inject
to a BMW with a 4 French guiding. And after that, we put the 4 French in the aorta. We exchange with the 35. So.
Yes. Okay. Okay. No way. Okay, please. Just inject a little bit. Not yet. No, not yet. Okay. Okay. Shall we inject that?
Yeah.
Yeah.
Oh, it's the standard
yes.
distribution, so it's only a loop.
Yes, only loop. I cannot pass through. No, very strong resistance. So maybe
if you could take a 4 French
yes.
GR4 catheter.
Yes. Do you have a 4 French catheter?
Yeah, Judkins right.
Judkins right or multipurpose?
Your French. Yeah. No, not the guiding. Just diagnostic.
Yes, diagnostic.
Ja, is goed. Nee, rechter.
Yes. Okay, so then you can put this catheter from the end.
What?
Yeah, we need water here. Okay. Oh, sorry. Okay, straighten, yes.
So what makes the resistance? The wire or?
No, tochastic.
Okay.
Okay, calm down.
Oké, hoe kunnen we het weer normaal? Oh, zo dus. You wait, quick.
Yes.
Staat hij weer in het al?
Oh, sorry. Can I see that? Okay. Also Another one, yes.
Dutch people are very sinuous.
Oh, terrible.
It's difficult for you.
Terrible. I think this one is not good for the sheathway system. Okay, anyway, first I have to pass the wire deeply into the ascending aorta. Okay, then I can remove the introducer from here. This is 4 French introducer, and then remove the catheter and this introducer together while keeping the wire in the ascending aorta.
Yeah,
Just
here
one.
you're in the ventricle.
Mhm.
Okay, let's take
Really? Okay.
Yeah, it was.
Okay.
How long is your wire?
This is 2 meters, 200 centimeters. Yes, please. Yes. Yes. Okay. Okay, come out. And then we put the catheter with inner catheter. And can I have a wet towel? Wet towel, please, because this is the hydrophilic. Thank you. Thank you. Yes,
Very hydrophilic.
Yes. Thank you. Okay, I'm putting this system, and I have actually no resistance here. No, you have to lock. Yes.
Do you open the skin for a...
Yes, by knife. But I think
When we put the 4 French before or 5 French before, we don't open, so...
in this case, I cut after the 4 French sheath insertion, but it was not enough.
Yeah, but Dutch are tortuous and they have very stiff skin also.
Mm-hmm. Yes, going. Okay.
I take it.
Thank you.
Ja, dat is even gevoelig. Mag ik even? Nee, even doorheen.
And I have to keep wet because otherwise.
Yeah, this is hydrophilic catheter,
Yes,
so you have
yes.
to make it wet. If
Yes,
it's
yes.
not wet, you won't move it. The problem with this guiding, sometimes you have to use a tissue to maintain because moving alone. So
Okay, then while
So I think this is a point you have to take care of
Yes,
because you can damage the aortic valve with the
Yes.
inside catheter.
yes, so I'm putting back the inner catheter and then pushing the outer catheter a little bit, and I hope that the catheter is in the coronary artery. I don't know.
I see it. You are in.
And also I have to remark very important point. The why we are putting 4 French introducer first, because otherwise we may forget to give heparin. It's very important.
Yeah, it is. So
Okay.
we control pressure.
Yes.
Okay, there's
Okay.
no damping.
No damping. Yes. Test, please. Yes.
Yeah.
Okay. Shall we take a picture? The
Okay.
size is okay.
Not yet.
Okay.
20.
20. I see. Yes. I'm familiar with this machine.
Wait for it.
Okay. I okay? Yeah, everything is very quite smoothly, going smoothly. Okay. Yeah, okay. Oh, that is the reason.
Yeah.
Okay. So
You can see, I don't know if you already had seen the film or the
No, this is the first
picture.
one.
Okay.
So this is a distal circ.
Yeah, the distal circ, yeah.
You don't plan to do the right CTO?
No, not here. And not today.
I have a question about this catheter. What do you think about this catheter? The most important, is it the reduction of diameter on 7 centimeters, or is it the coating?
Yeah, that is a question for Dr. Saito.
It's the best aspect of this catheter. Is it the coating, or is it
Coating.
the reduction of diameter
coating.
on only 7 centimeters? Because okay, we put short sheath, so okay, we have big diameter on 7 centimeters only. So, do you think the same coating has to be used for smaller catheters? I mean, if we are able to build the 5 French with double wire, double balloon. Do you think that for 5 French will be also very important to put a good coating like this one?
Yes, yes.
Because another problem with the coating is that the catheter is moving sometimes.
Yes.
So we have to sometimes we have to fix it at the skin, because while working is going back, going out.
Yes. Okay. Anyway, I think this catheter is quite nice. Was nice. Okay. But the problem is this catheter was developed several years ago, and I think this is my personal opinion. This catheter must have some improvement.
In what way?
Maybe for myself, the catheter wall is too thick compared to the inner diameter or outer diameter.
I have another point. When you are working a long time with this, the thermal stability is not as good as in other catheters.
Okay, so the predilatation.
So let's look at the film once
Yes,
more.
yes, please.
And see what size we should take. Here, 3.5 again. What do you think?
No, because this is sunk, so it's magnified, enlarged compared to the real diameter. So I think 3 millimeter is fine.
3 millimeter, 15.
Yes. I want to predilate, of
Yes.
course. This is a BBS.
Yeah, BBS.
Okay.
Okay, 350.
So do you have any definite criteria to use BBS?
Well, we are going to participate in the AIDA study, which is a randomized controlled study comparing BVS versus science
expedition.
It's an all-comer study.
I see.
Here, this protocol is not running yet here. It is at the Academic Medical Center in Amsterdam. They already are recruiting patients. So it will be an all-comer study. And of course we look at age, distal location, if the patient needs future bypass surgery. What about the backup of your catheter? Is that adequate for?
In this case, not enough. So this is still not.
Yeah,
Okay.
no, you-
Okay, here. Okay. Go. Okay.
Yeah, you're right in the center. So we predilate with 12. Je kunt nu wat druk op de borst krijgen. Patient has some
Chest pain. Okay.
Yeah.
Okay. Okay.
Yeah.
Enough. Yeah.
Okay.
Okay. Shall we take a picture? I think maybe 3 millimeter is too small.
So we take 3.5?
3.5.
Yeah, okay.
3.5.
Heb je nog een 3.5?
Dr. Saito, is
Yes.
this catheter easy to manipulate when you're doing deep intubation?
No,
because
no,
of
no.
the hydrophilic coating. So what
No.
do? You take a gauge to hold it, or
No, I think it might be a little bit dangerous because this catheter shaft is so strong. It's not, I think, not adequate for the deep engagement technique.
Kom maar naar mij luisteren. Gaat het weer, meneer Staal?
Ja hoor,
Ja, mooi.
maar gewoon door hoor.
Ga gewoon door.
Ja.
Oké. Je bent een dapper man.
Ik ben niet voor niks in dienst geweest.
Oké.
Okay, here. Maybe test, please. Here. Okay, okay, here.
Yeah.
To 12.
12. Oh, that's better.
Okay.
Ferdinand, is that the balloon or the stent?
No. This is
a
the
balloon.
This is
Still
the balloon.
balloon, okay.
Yeah, it was a little bit undersized, and we don't have proper size for the before we place
Yes.
it. Yes.
This is 3.5. And then I can take a 3.5 millimeter BBS.
Okay, 3.518.
Short.
Yeah.
Yes.
On this point, do you have any concern that the stent will not cross because it has some more volume? Your backup of the catheter is not optimal. Are you already considering?
But actually,
Placing
you know,
next slide.
I have a 40 patients experience
Yeah.
with BBS, and you know, I did not have any patient with cannot recross the stent,
good.
and this BBS is quite good for the trackability before placing the stent, and after the stent was placed in the region, we have to be very, very careful for the recrossing of something like a balloon or IVAS or OCT. Sometimes we feel a big resistance. Okay.
And this slow inflation, that must be against your basic nature, because in the time that we inflate the BVS, you already have done a case in your lab. So what's you
Yes.
have enough?
Yes, you know, I use the BBS only for the clinical trial, so it's totally controlled by the protocol, so I have to follow. So the recommendation is just two atmospheres every five seconds. Yes. But in my cath lab, the clock is moving faster. Oh, I have some resistance here. It's quite unusual. So I'm pushing this guiding catheter a little bit.
Do I need to make vacuum on the balloon?
No. So I'm pushing
you are-
very slowly. Yes.
Yeah, it's very important not to
Yes.
use this daughter technique.
Yes.
So just gentle advancement. Shall we
Okay.
check?
Yes, please. Okay.
Yeah, that looks good.
Yes, yes.
So here, you take your Japanese time
Okay.
to
Okay. Okay.
inflate the stent.
2, 4.
This is not 5 seconds.
Ready?
Maybe Japanese seconds.
Okay, 6. 8.
That's better.
we are learning.
I'm running. Yes,
Quiet.
I'm running. This is a French clock.
Yeah, that's a French
Always
clock.
slow.
No, the French clocks are on strike, so they don't.
On strikes. Okay. And 12. Okay, then I have to keep for 30 seconds. That is a recommendation.
Okay. Well, we obviously did not do that on the previous patient.
Oh, really?
We post-dilated.
But sometimes post-dilation balloon cannot pass through.
Yeah, I agree with this.
Yeah. Okay, 30 seconds. And then when I'm retrieving this system, I have to be, guaranteed that the dye was, every dye is going out. It's very important. Otherwise, we destroy the structure of the BBS. It's very fragile.
Do you routinely post-dilate, or it
No,
depends on the
no.
result?
In the most of the cases, I never do
That's
post-dilatation.
good news.
Okay, shall we take this?
Yeah.
Yes,
Yeah.
perfect. The proximal segment is narrow
Yeah, but
compared
now-
to the,
yes.
but I do not touch. Okay, I will remove the wire. Is okay,
Okay.
and then take a final cine angio. Okay.
Maybe some nitrates because was
okay.
the crossing was a bit difficult.
Yeah,
Maybe
but
it's a
now
spasm.
it also
Nitro.
looks a bit more
Nitro.
severe because of the possibly oversized segment of the.
How much I can give?
Yeah, 200.
Everything?
No.
No? I don't know the concentration. How are you feeling? Everything fine, okay? Okay. Yeah. Okay.
I think it's fine.
Yes.
Very nice result.
Thank you.
Congratulations.
Thank you. And we will be, still we have time. We have to
Yes.
show the. So can I have a TR band, please? Okay, I will remove this system.
Do you leave a wire inside the guiding or not?
No.
No.
We are doing the same. We remove like a sheath.
Okay. Okay, can you focus here? Yes. Okay, I'm putting the TR band here, and then. Something. Oh, yes. Okay.
Okay.
Okay. And then. Okay. Are you ready? Should be ready. Okay, okay, push. Okay. Congratulations. Okay.
Okay, I think we can.
Thank you.
Thank you, Dr. So, I think we can